Thank you, Raj, for the kind words. I hope I don't run over, but I have a lot to cover in 15 minutes, so I'm going to get right to it. We've had some really amazing progress in the past 10 years in terms of developing prognostic models, assessing risk, finding new ways to stage the disease in PBC, and really allow our patients to look forward to a long, if not normal, life expectancy. And now we have exciting new therapies that are focusing on patient-reported outcomes and quality of life. So here are my disclosures. So one of the things that I want to start by mentioning is that our concept of risk assessment in PBC is evolving. We used to think that it was really just stage of disease. Then we developed prognostic models with alkaline phosphatase and bilirubin, and those have really gotten fine-tuned over the last few years. But several new pieces of work have come to light recently. First is racial disparities and the influence of race. And in fact, Dr. Lily Dara, who's here, just had a paper on Hispanic patients with PBC and their outcomes. Dr. Gordon from Detroit has been publishing for a while on the experience of Black patients with PBC, and they can be quite different. So keeping in mind racial determinants and racial diversity is very important. There may be differences in prognosis. Age at diagnosis is now really, really important. So we know that patients diagnosed before age 43 have a very different outcome. Patients diagnosed before age 62 have a different outcome. And older patients tend to have a more benign outcome. Sex has always been an important point in PBC. We always thought that the sex ratio was 9:1. But I was recently in Italy, and the data from Europe, where there's more testing and possibly more evaluation, suggests that the sex ratio for men and women with PBC may be as low as 5:1 or 6:1, not 9:1. And there are some data with concern about liver cancer risk in men, but a very nice paper from University of Miami with Dr. Binu John has shown that, in fact, HCC risk may not be different in the VA population. Antibody profile is important. We know, for example, patients who have the GP210 disease-specific ANA have worse outcomes, and we obviously recognize that there are biopsy features that might be important. Incomplete response to UDCA is well recognized now as a risk factor. So I like to think about classifying risk in PBC in this manner, which is really stratifying the patient into average, intermediate to high risk, and then advanced disease, with the average risk being the patient who has a mild elevation in alkaline phosphatase, normal bilirubin, normal albumin, and has minimal or no fibrosis. Whereas patients who have advanced disease, obviously we as GI hepatologists are very comfortable with identifying who needs early referral for liver transplantation, and we're recognizing that we should be more focused on fatigue and pruritus. But the patient who has younger age at diagnosis, persistently elevated alkaline phosphatase, maybe not an abnormal bilirubin, but a total bilirubin over 0.6, may be somebody that we might consider a high risk, and fibrosis, of course. So personalization based on risk profile is becoming more important. Now, we've all known about the Barcelona criteria, Paris 1, Paris 2, Toronto, et cetera, and we have used these dichotomous models to predict outcomes based on global PBC study group, but we also know now that the development of the Globe PBC score and the UK PBC score provides continuous risk assessment rather than based on dichotomous variables such as bilirubin or alkaline phosphatase below or above a certain cutoff. And so I think that's something that's really important. By incorporating these into your clinic, into your assessment with the patient, I think we can do a much better job in risk assessment for the patient over a longer period of time, and we can reevaluate this, and patients can evaluate this based on their own laboratories. So we have dichotomous criteria and more composite continuous criteria that once again have really moved the needle forward, because we're able to risk assess patients over 10 years and longer, as opposed to the old Mayo risk score, which was really over a 5-year period and really determined patients in terms of priority for liver transplantation. And we also know now that responders do much better than non-responders, and there are several recent data that even have provided even more granular information on assessing this from real-world cohorts. So liver stiffness measurement is now well established as a risk prognosticator in PBC, and this is a lot of this has been driven by Christophe Corpechot in Paris, and it just shows you, for example, that combining GLOBE score, which is based on blood tests and age, and looking at FibroScan or liver stiffness measurement at diagnosis and then follow-up, can provide cutoffs that are really useful. So, for example, if a patient has less than 8 kilopascals, they have very, very good outcomes. More than 10 would put the patient at risk for moderate to advanced fibrosis, and higher than 10 would be patients who have advanced fibrosis. So we can combine liver stiffness measurement and GLOBE score to really evaluate clinical outcomes more effectively. Now, this is a paper we recently published, and with data shown on the right. We have these dichotomous variables that we've used historically, and that's been a criteria for entry into clinical trials, and it's been a primary composite endpoint for response in clinical trials recently with several therapies. And that's been useful, but they're really based on assessment at 1 year after starting URSO and then at periodic intervals. And we know, for example, bilirubin has a continuous function in terms of predicting outcomes, as shown on the left from a paper from Murillo Perez that was published in 2020. Shown on the right is data from a claims database and real-world evidence where we looked at risk of hospitalization, risk of liver decompensation, transplantation, so mallow, hard outcomes, however you want to call it. And we tested the hypothesis that, in fact, area under the curve might be a good way to think about stability for the patient. So this looks at what percentage of the time under observation did the patient have an elevated alkaline phosphatase and an elevated bilirubin. And as you can see, the higher the percentage of time that they were above these variables, these threshold levels, the greater the risk of adverse outcomes. Intuitively, that makes sense, but we haven't really thought about thinking about that. But it has clear implications when we're talking about therapy, because it really reminds us that we don't just test the labs once a year and not think about it in between, that we want to look at the patient over time and try to maintain them in that biochemical response for as long as possible. We have another paper that we just published showing, in fact, the relationship between treatment persistence and outcomes. And it shows that patients who have breaks in therapy and patients who have shorter duration of therapy over time have worse outcomes in terms of hard outcomes like decompensated liver disease, etc. And that was in elementary pharmacology and therapeutics also. So I would encourage you to look at that paper. So we know that the thinking is evolving, so we're not just testing a patient at diagnosis, waiting a year on URSO, seeing how the patient does and risk stratifying them. We're gathering data at baseline before we start any therapy, and we're trying to calculate their risk continuously over time based on a variety of different factors. And this is now starting to come out in terms of publications, where you can see on the left, baseline liver stiffness predicts outcomes, and also change in liver stiffness over time is also associated with an increased hazard ratio or risk of adverse clinical events. So again, a very sort of intuitively obvious thing, but something we're now starting to get data to show. So when you look at prediction models, they're complementary to fibrosis stage. So one of the other things that we're sort of trying to encourage people to do and trying to do in our own practice is to incorporate where is the patient in terms of their biochemical tests and what is their stage, because they're complementing each other in terms of predicting outcomes. So one way to do this would be look at the GLOBE score after a year of URSO therapy, look at changes in serum bilirubin. If it's over 0.6, that might put the patient at a higher risk category, and then use those dichotomous variables, but also consider including something like FibroScan. So with that, let me talk about treatment. So we all know URSO is accepted as first-line treatment, but many of us haven't seen these data in a while. But if you look at some of the early data with URSO, you can see that URSO was very effective in lowering alkaline phosphatase. And in fact, when URSO was approved in 1999, 97, 99, we were able to show from large cohorts that it reduced the need for transplant. And in fact, the number of liver transplants for PBC has gone down continuously since that time, but the average age of transplant hasn't changed. Again, identifying the population with severe disease that we need to be mindful about. And there's no question, it's been a while since some of you may have seen these data, but there's no question that if you look at URSO and long-term survival, there is a clear benefit in terms of hazard ratio of almost 50% reduction, more than 50% reduction with URSO therapy in terms of need for transplantation. So it doesn't just improve the blood test, it actually improves outcomes. So with that, let's move on and talk about PPAR agonists. Obviously, obeticholic acid is now not available and was withdrawn voluntarily by the manufacturer, but we have elafibranor and seladelpar, which were both approved in 2024. Elafibranor being a dual PPAR alpha delta agonist, given as an 80 milligram tablet based on the ELATIVE trial and approved in various regulatory jurisdictions, with seladelpar being a PPAR delta agonist, given at 10 milligrams daily, and approved now also by the FDA, the EMA, and in the UK as of last year. So here's the pivotal data with elafibranor. Here's the treatment difference of 47%. And I think it's important for us to always be thinking about treatment difference rather than just looking at the response in the treated population, because the placebo response rates seem to be variable. And these are obviously not head-to-head studies. But very impressive reduction in alkaline phosphatase of 47%, so highly statistically significant in terms of reaching those what we now call POISE criteria for the original POISE trial of obeticholic acid. Patients reaching alkaline phosphatase less than 1.67 with at least a 15% reduction, total bilirubin below the upper limit of normal. And here's the rate for normalization. We didn't see this with obeticholic acid, and this is for reasons that we don't have time to get into, but clearly we're now starting to see normalization of alkaline phosphatase with PPAR agonists, which is very exciting and really showing us that we can achieve what our goal is of complete biochemical remission. You see a nice steep reduction in alkaline phosphatase as early as 4 weeks into treatment. With pruritus, you can see that with the ELATIVE trial, there was not a statistically significant difference in terms of response in patients with moderate to severe pruritus, but there was evidence from PBC-specific itch measures such as PBC-40 itch domain and 5D itch that suggested improvement with elafibranor. And this is very reassuring because, in fact, with obeticholic acid, as we all know, itching got worse. Here are the adverse events, and you can see that, in fact, these studies, both the elafibranor and the seladelpar, which I'm going to show you in a minute, were done during the COVID-19 pandemic, so that is a number one adverse event in this particular study, but they're largely GI related with a few other side effects, but discontinuation due to adverse events appears to be not different compared to placebo, and severe adverse events seen in about 11% of the population. Now, response was a study with seladelpar, and again, a very nice difference in terms of seladelpar treated versus placebo treated patients with a treatment difference of 41.7%, again, highly statistically significant, so very impressive result. Here we were able to see alkaline phosphatase normalization in 25% of patients at 12 months, and a similar prompt and sustained reduction in alkaline phosphatase that occurred at baseline at 4 weeks into treatment and was sustained over therapy. With seladelpar, we did actually also observe a statistically significant difference in terms of worst-itch NRS in patients with moderate to severe pruritus, and this was very impressive. And you can see that this was a change that appeared at 6 months and was sustained over the course of therapy. Side effects with seladelpar, again, COVID-19 being the number one, with a similar type of GI-related side effects that we've come to expect from the PPAR agonists to be clustered with a few other side effects that seem to be present at maybe numerically slightly higher rates than placebo. But once again, adverse events resulting in treatment discontinuation, in fact, not different and in fact lower than placebo numerically here, and serious adverse events in a comparable number of patients. So in summary, risk stratification is important in PBC. Hopefully I've given you some new ways to think about this. Should accompany assessment of disease stage. URSO clearly improves long-term outcomes. Second-line treatment, we're fortunate to have 2 therapies that are now highly effective, and we need to consider this early based on biochemical response stage and patient risk. And we have data with the PPAR agonists suggesting improvement in pruritus, which I think is very encouraging, and alkaline phosphatase normalization, which is also encouraging, and confirmatory trials are ongoing. Thank you very much.
All right, thank you so much to the organizers for having me. Dr. Kowdley did a great job giving you an overview of PBC. My job is to now switch gears a little bit and talk about the other cholestatic disease, which unfortunately hasn't had as much progress in the last few years, and talk about primary sclerosing cholangitis, so PSC. So we'll discuss the sort of current risk assessment and our management. These are my disclosures. We'll also review what our current management of PSC is in terms of medications, malignancy screening, and some extrahepatic symptoms. So just to recap, remember that primary sclerosing cholangitis is an autoimmune liver disease that primarily affects the medium and the larger sized bile ducts, as opposed to PBC, which affects the smaller bile ducts. The prevalence indicates how rare it is. 6 to 16 people are affected per 100,000 in North America and Europe. Predominantly affects males, so 70% male predominance, and ages 30 to 40. About 50% will present with symptoms initially, either intermittently or consistently at the time of their presentation, and another 20% will develop symptoms at some point during the course of their treatment, or during the course of their disease within 5 years. The most common coexisting autoimmune condition that goes along with PSC is inflammatory bowel disease, so ulcerative colitis being more common than Crohn's or indeterminate colitis. It's a very slowly progressive disease, so like cholestatic diseases often are, it can take a while to lead to the diagnosis of it. The most common test that we check to sort of monitor for disease activity is liver biochemistry, so the alkaline phosphatase. But we know that the alkaline phosphatase levels do fluctuate significantly during the course of the disease and doesn't really plot with the ongoing progressive nature of the disease. So instead, what we have found is using fibrosis markers and serum fibrosis markers, in particular the enhanced liver fibrosis, has shown better correlation when we are looking at other elastography measurements like transient elastography. So fibrosis markers probably a better marker of the progression of disease more so than the alkaline phosphatase is. We also know that there's variable levels of IBD activity. Oftentimes when the disease is early, the IBD activity tends to be a little bit more pronounced. As the disease becomes more severe and more progressive, the IBD activity tends to quiet down. There's likely a significant interplay as well between the gut microbiome and biliary inflammation, and we see that there's some biomarkers that are associated with PSC prognosis and others that exert a pathogenic effect. And some of the microbiome biomarkers that have exert a pathogenic effect might persist after transplant and may play a role in the risk of recurrent PSC after transplant. And then lastly, we are always monitoring our patients for specific clinical events. And these are important ones that we often will discuss with our patients. So the risk of bacterial cholangitis, which often happens when there's larger ducts involved, the risk of cancer, including both cholangiocarcinoma and colorectal cancer, and lastly, the risk of progressive liver disease with cirrhosis and the decompensation events that can occur with end-stage liver disease. Unfortunately, risk assessment in PSC remains quite a challenge, because clinical complications like malignancy and severe biliary strictures can develop even in early stage disease. So we see it before there's cirrhosis and before there is advanced fibrosis. But we do know that it's important in terms of assessing these risks early and assessing it with our patients continuously when we're seeing them in our practice, because it helps us prepare our patients for what is to come, and it could be clinically beneficial as well. So what tools do we currently have? These are non-serum tools, so non-blood-based tools that we can use to assess prognosis in PSC. Liver biopsy, we know, is not recommended. So histology in PSC, we know, is hampered based on sampling variability, based on location of where the strictures might be and the extent of cholestasis. There's a lot of variability. So it is not recommended in clinical practice, and really the role of liver biopsy is purely in terms of clinical trials right now. Liver stiffness measurements with transient elastography or MR elastography do correlate well with progression of liver disease and should be assessed on a periodic nature in patients with PSC. And if these tools are not available, using the enhanced liver fibrosis score, like I mentioned earlier, can also correlate well with the progression of their disease. The radiographic tools that we have include MRI and MRCP. And with itself, while it's helpful to determine whether or not there's new larger duct strictures that are developing or whether or not there's signs of portal hypertension, liver dysmorphia, you can kind of, in a subjective eye or kind of looking at the scans yourself, see if there's been more progression, but there are objective measurements that our radiologists have used, namely the Anali score, to sort of quantitate if there is significant intrahepatic ductal dilation, if there is dysmorphia, if there is portal hypertension, and using that with liver stiffness measurements does actually correlate well with prognosis. And then lastly, the MRCP Plus, which is a newer tool. It's an AI-generated tool that is a post-processing tool on top of MRCP. Using MRCP Plus, we do know that this correlates as well with liver stiffness measurements, with Mayo risk scores, and with other serum markers of prognostication. So it's objectivable, it's reproducible. The question is, how accessible is it right now for our patients? But it is a tool that can be used to help prognosis. This is what the MRCP Plus looks like if you haven't seen one before. So it is quantitative metrics on the biliary tree. It gives you number and length of strictures, of dilation, of duct diameter, and you can use it with biomarkers, and it does correlate well with other risk stratification scores, like I mentioned. This is an example of a patient that had an MRCP Plus at baseline and at 1 year follow-up. And if you looked at other clinical parameters, there were no changes in liver stiffness measurement based on VCTE or biochemical measures, but we do see that there's some changes noted on the MRCP Plus. So kind of interesting to see whether or not it's actionable remains to be determined. So what other tools do we have? These are other prognostic calculations that you can do with your patient in front of you in the clinic, as long as you have laboratory values in their clinical data. The revised Mayo risk score was traditionally the risk assessment tool that we used, and it was widely used for a long time, but it's been replaced now with some of the newer models. And that's mainly because it has very low utility in early stage disease, and it cannot predict reliably what long-term outcomes are. So the other models that we use, the Amsterdam-Oxford models, used primarily in those that might have overlap syndrome, and then the ones that are used traditionally for PSC itself are UK PSC and Presto. And I will do these in practice, usually once a year, every 2 years, to help see how my patients are marching along in their journey in their PSC. Are they relatively stable? Do I see that there is some progression in their disease? And these are readily accessible tools that you can do with your patients in the clinic. The one challenge with these tools is while it predicts the progression of fibrosis and the time to clinical event, including transplantation, these don't predict cholangiocarcinoma risk. So that remains one risk that we cannot reliably predict. Management of PSC. So medical management, unfortunately, there are no approved therapies for PSC. We rely on counseling our patients for symptoms and monitoring their symptoms. And we spent a lot of time talking about malignancy screening and other extrahepatic symptoms in our practice. What we do sometimes, what you see commonly used for our patients is ursodeoxycholic acid, and Dr. Kowdley really nicely reiterated to us how there is clear survival benefit with UDCA and PBC that hasn't been demonstrated in PSC yet. The largest study in PSC had about 200 patients or so that were enrolled and did not meet full enrollment, so wasn't able to necessarily show that there was a significant benefit. Overall, though, we do think that the use of UDCA does improve liver biochemistries, or it can improve liver biochemistries, and that if it does improve liver biochemistries, there may be an improvement in long-term trajectory. The high doses of UDCA are not recommended because it is associated with a higher risk of death and liver transplantation and potentially higher odds of colorectal cancer and PSC-IBD. This is the study of UDCA and PSC that did not necessarily meet clinical significance because of, it was underpowered essentially to show this difference, but it did show that there was improvements in alkaline phosphatase and ALT values. And what we have subsequently seen in several studies thereafter is that there is an improved prognosis in people with PSC where liver biochemistries, and in particular the alkaline phosphatase, does normalize or improve. And that could be with or without the use of UDCA. There was other studies that have looked at the withdrawal of UDCA in people with PSC. And when you withdrew the UDCA in these patients, there was a recurrence of significant symptoms, including fatigue, pruritus, increased Mayo risk score, and increased ALP. So our guidelines now recommend that we should consider UDCA at a dose that's somewhere between 13 to 23 mg per kg per day, depending on which guideline you're looking at, in those that have persistent elevations in ALP and GGT. And we might be able to see that there is some potential improvement in their prognosis. What else is available? Well, nothing else is available. What else has been studied is norursodeoxycholic acid in PSC. So these are the results from the, or interim results from the phase 3 study were discussed at EASL in last year. So this is a side chain, shortened side chain of UDCA that improves the colohepatic circulation. And it prevents amidation. We think that there's improved bicarbonate-rich layer, and it could be more cytoprotective than UDCA is. So in this phase 3 study, there were 220 patients that were randomized 2-to-1 to receive nor-urso versus placebo. And overall outcomes that they were looking at was a decline in alkaline phosphatase and no worsening in fibrosis. So this study showed that 15% of those that received nor-urso met that primary outcome at 96 weeks compared to 4% in the placebo arm, which was promising. This study is ongoing, and there are additional results that we presented, I think, when the study completes its 192-week enrollment period. And those that were not on urso in this study did appear to have greater benefit than those that were on urso. There were in general, the safety profile that was reviewed so far indicated an excellent safety profile of nor-urso, and the rates of AEs or SAEs were similar compared to the placebo arm, and it was generally well tolerated. Antibiotics have been studied for a long time in PSC, including vancomycin, metronidazole, rifampicin, minocycline, and there are pediatric colleagues I know in the audience that will know more about this than I do, but one of the most popular studied antibiotics right now in PSC-IBD has been vancomycin, primarily because of the impact that we've seen in children that have PSC-IBD that receive vancomycin having improvement in their IBD. So in this study in particular that looked at 280 kids that had PSC-IBD that were treated with vancomycin, 70 were treated with vancomycin, and it seemed like the likelihood of endoscopic remission of their IBD was much higher. And there were improvements, I believe, in the biochemistries as well, in terms of liver biochemistries as well. So there have been several smaller case control studies that have looked at vancomycin. The Mayo group also had an RCT with vancomycin that did complete enrollment. So I think more to come to see what the effect is in PSC. In terms of ongoing trials in PSC, unfortunately, I don't think the bexotegrast is moving on into future phases with PSC, but it did look like there was stabilization in enhanced liver fibrosis with this integrin molecule and improvement in MRI parameters. But there are other promising studies that are underway, and we are looking forward to participating. We're looking forward to seeing the results of some of these studies. So elafibranor is being studied in ongoing trials in PSC. Bezafibrate is as well. CM101 had some promising phase 2 data, and we look forward to seeing if they'll progress with phase 3 as well. In the last few minutes, I want to talk about what we do currently do with our patients. So malignancy screening. Cholangiocarcinoma screening is incredibly important. The lifetime prevalence of, or the lifetime incidence of cholangiocarcinoma in an individual patient is about 15 to 20%. That's a really, really high risk when you're talking to a young man that's in front of you that's 30 to 40 years old. So this is something that we have to really keep on top of in our clinic. We recommend doing MRCPs with CA19-9 annually, and we do know that regular surveillance is associated with higher 5-year survival. So there was a nice study that looked at those that had regular annual or biannual screening MRCPs compared to those that didn't, and that's likely due to earlier detection. Colorectal cancer screening, those that have PSC-IBD, is recommended yearly, with colonoscopy beginning at age 15 when you're diagnosed in the pediatric population. Gallbladder carcinoma is recommended with an yearly ultrasound, and if there are polyps that are detected that are less than 8 millimeters, then to shorten that frequency to every 6 months, and then hepatocellular carcinoma screening is recommended every 6 months with cirrhosis. So with cholangiocarcinoma screening, we're getting the MRCPs. What do you do with that information? If you have a relevant stricture, meaning a stricture of the CVD or the larger hepatic ducts, it's important to follow that up with an ERCP with biopsies or brushings for Fisher cytology. Sequencing from cytology is not routinely recommended yet, although that is available at certain institutions. While it improves the sensitivity, it remains not necessarily the most specific right now, but can be added if there is concern. It's important to think about the indications for ERCP apart from whether or not there's dominant strictures and concern for cholangiocarcinoma. Oftentimes we do see that just for the diagnosis of PSC, patients are getting ERCPs, and that's not recommended and it's not needed unless there's true concern for what that dominant stricture, that larger stricture might be. So if there's new or worsening pruritus, if there's unexplained weight loss, worsening in liver biochemistries, elevated CA19-9, those are all potential indications to proceed with an ERCP. A reminder that ERCPs in our patients with PSC do carry a risk of cholangitis, so peri-procedural antibiotics are recommended. 1 to 3 days, usually at the time of the ERCP, and then 3 days following the ERCP. They also carry a risk of pancreatitis, and our advanced endoscopists, or hopefully yours, are using indomethacin or putting a PD stent to reduce that risk. And it's important to replace these plastic stents and make sure your patients aren't lost from ERCPs if they did have a stent put in. Management of extrahepatic symptoms. So I did mention earlier that about 50% of our patients with PSC have significant symptoms at the time of their diagnosis, and up to 20% more will develop it during the first 5 years of their diagnosis. The most common symptoms are pruritus and fatigue. There is a host of medications that are non-FDA approved for the management of cholestatic pruritus right now, Cholestar being one of them, and others that are being studied, including volixibat, which is being studied in phase 2 trial for PSC-associated pruritus. And then lastly, fatigue and brain fog. This is a hard one to combat in clinic, and I don't have great tools to do this with our patients, but I will validate that their symptoms could be related to their cholestatic disease and emphasize that it's important to use pacing strategies to still be physically active. And we are fortunate enough to now have a psychologist that's part of our group, and I will refer many of these patients for therapy with her, just to, for acceptance, commitment training for CBT as well. And I will always offer resources through a lot of our patient advocacy organizations, which I think makes a big difference for our patients. So in summary, PSC is very heterogeneous and it has variable risk of progression. The risk of decompensation or transplantation can be assessed with some clinical prognostic tools and non-invasive measures. There are no currently approved therapies for PSC, but you can consider UDCA if there's ongoing elevations in ALP and GGT values. There's many trials that are ongoing or about to start, so please consider clinical trials for your PSC patients. It's hard to sometimes fill these trials because it's a rare disease, so really think about whether or not your patients may qualify. Malignancy screening remains a cornerstone of what we're doing in our practice when we talk about our patients, and it's really important to inquire about extrahepatic symptoms, including pruritus and fatigue, when you have these patients in the office with you. Thank you so much for your attention.
Thank you very much. It's a pleasure to be here this afternoon. I'd like to thank Drs. Kowdley and Vuppalanchi for the kind invitation. In the time allotted to me, I'd like to talk to you about new treatments for PBC and PSC, which used to be a relatively easy task in 10 minutes, but not so much so now that we fortunately have more developments. These are my disclosures. I think Dr. Kowdley did a fantastic job covering PBC in a much more nuanced fashion. My bullet points here reflect that PBC, again, is not so rare in the proper context. It seems to be increasing in incidence, seems to be more aggressive in men, and we universally agree that alkaline phosphatase is an accepted surrogate regulatory endpoint, not so much so the case for PSC, and more on that in a second. I only show this slide also to provide some context for what I'm going to talk about next. Up until September 2025, we used to have 4 approved treatments for PBC, UDCA, the only first-line treatment, and elafibranor and seladelpar, 2 PPARs, which achieve 15 to 25% alkaline phosphatase normalization. We did have obeticholic acid, the only FXR agonist that was approved. And while this was not significantly used, at least in new patients, it did at least have the opportunity to potentially participate in some meaningful way in clinical development. And that, I think, is in limbo right now. And that will be at least part of my discussion of future treatments. As is often the case in medicine, past is prologue, right? And perhaps no better example of this than the classic Christophe-Corpechot paper in the New England Journal of Medicine from 2018. I'll remind this audience that this was a randomized placebo-controlled trial of bezafibrate in patients with PBC. The beza, of course, is a pan-PPAR agonist, which was dosed in this particular trial at 400 milligrams once daily. The inclusion criteria, which Kris went over, would be the Paris-2 criteria, and these were patients who were UDCA treated or intolerant, typical with the clinical trials that have followed. The primary endpoint was quite ambitious. It was complete biochemical response at 24 months, which means every liver test needed to be normal: alk phos, total bilirubin, aminotransferases, albumin, and prothrombin time. There was, of course, a subset analysis for alkaline phosphatase normalization alone. And as you can see here, compared to placebo, there was a very significant number of patients that met the primary endpoint, this complete biochemical response endpoint at 24 weeks. In fact, by the end of 24 months, I'm sorry. In fact, by the end of the trial, 31% of patients had met this. In fact, if you just look at alkaline phosphatase normalization, 56% of patients had met the endpoint versus 2% placebo. Pretty damn good if you ask me. Now, this is not the full context, of course. The full context is that twice as many patients in the beza arm had myalgias compared to patients who took placebo, 20% versus 10%. 5% increase in serum creatinine compared to patients who got placebo, including 3 patients who actually got significant kidney dysfunction. 2 had stage 2 CKD, 1 had stage 3 CKD by the end of the trial. And of course, 3 patients who had AST, greater than 5 times the upper limit of normal, of which 1 needed glucocorticoids, and all 3 were withdrawn. So there's no magic pill, of course, and this is one such example. But clearly, one would argue that these are fairly encouraging findings in this setting. Of course, the future of beza was going to be its combination with the FXR agonist obeticholic acid, and this, at least for the foreseeable future, is all the data we're going to be seeing. This was presented in abstract form at the AASLD, at EASL in 2024. 4 arms: beza 200 milligrams immediate release, OCA 10 milligrams with beza 200 milligrams, beza at 400 in a sustained release form, and OCA 10 milligrams with beza at 400, randomized 1:1 to 1:1, given for 12 weeks, an open label extension out to 96 weeks, which was the context of a phase 3 trial. None of this is currently ongoing. If you look at the data at month 6, you will see that alkaline normalization was achieved ranging from 37% in the immediate release 200 milligrams beza arm, all the way up to 61% in patients who received the higher dose of beza at 400 milligrams and OCA at 10 milligrams. If you look at biochemical remission, the more ambitious endpoint of not only normalization of these parameters, but also more than 40% reduction in alk phos, GGT, ALT, AST less than upper limit of normal, and total bilirubin less than 0.6 upper limit of normal. That was achieved, again, in roughly the same percentage of patients, anywhere between 32% to 67%. Of course, there were some side effects, and a recurrent theme here is anytime you introduce BISA, you potentially introduce some increased risk of myalgia, which you can see in the BISA arms to your right at 10% in the 400 milligram arms, and I believe 6% in the combination of OCA and BISA. Now, these are very small numbers. Each arm has about 19 patients. There's also some mitigation of pruritus in the BISA context, where patients who took BISA had less itching. This, by the way, was shown in a separate trial called the Fitch trial for fibrosing cholangiopathy, so makes biological sense. But the upshot of all this, and why I'm mentioning this even though it may go nowhere, is that if you look at normalization of alk phos, this is by far the most ambitious and most optimistic estimate of the result of an intervention that we've had in the BISA 400 OCA 10 group. There are, of course, other mechanisms of action. I think most of us think that if you use a PPAR-driven mechanism, such as the pan-PPAR-BISA or some of the other drugs in development, you're probably going to reach a ceiling where you cannot improve this beyond that, and so novel mechanisms of action are very much needed. This is very much an out-of-the-box way to look at this. This is a drug that has, this is an investigational agent that has received orphan status, and it is relying on a proprietary technology whereby you can encapsulate many different antigens. This is not just being done for PBC, this is done for myasthenia gravis and other diseases. And by doing so, you actually induce energy to potential immune responses that potentially damage cells targeted by various immune-mediated diseases. This seems to work both on humoral immunity, so B cells, and also cell-mediated immunity. And this is what this CNP-104 drug is. This is a drug that targets, in this particular case, PDC-E2, which clearly we think is significantly implicated in the interlobular bile duct injury that occurs in the setting of PBC. These are day 120 data. This was presented, I think, a year and a half ago now at EASL. And if you look at the data here, these are infusions which were basically given as a loading dose and an 8-day dose. There are 3 doses, 4 milligrams per kilo, 8 milligrams per kilo, and placebo. The proof of mechanism of action basically relies on target engagement. If you look at Th17 pathogenic cells, which are thought to be very significantly implicated in the pathogenesis of PBC, that clearly declines at day 120. Notice that after the patient stops treatment, by day 180, you have a rebound in these cells, which suggests that this was indeed a byproduct of receiving the medicine. There's also some liver stiffness data, which I think look less convincing in my opinion, whereby you have at least a stabilization or maintenance of liver stiffness over the 120 days of the conduct of the study, and this does rebound up after the drug is discontinued, or the investigational agent is discontinued, versus placebo, which actually continues to slowly march up over time. So promising data, but obviously much more needs to be done. PSC, as Dr. Goel mentioned to us, is a progressive cholestatic liver disease. Typically in a young person, over 2 decades of life, a patient might progress to the point where they might die or need a liver transplant. There is no proven treatment. There's a significant percentage of patients who have IBD. Quality of life is significantly impaired, and most importantly, regulatory endpoints are in flux. These include alkaline phosphatase reduction, some markers of inflammation and fibrosis, histology, and composites including imaging like MRCP+. Another drug that Dr. Goel mentioned to us, and I'm not going to dwell too much on this because she covered this very nicely, is norucolic acid, aka NOR-UDCA. This is a drug that is primarily working on both cholangiocytes and hepatocytes through a hyperchloremic effect, which downstream induces a variety of anti-proliferative, anti-fibrotic, and anti-inflammatory effects. This is, of course, a synthetic engineered bile acid, so one would expect some degree of similar profile to UDCA, although potentially that can be mitigated by the engineering of the drug. I think Dr. Goel mentioned most of this, so I won't spend too much time on this. This is an ambitious program, which is going to span all the way out to 192 weeks. I'll show you the 96-week data with the primary endpoint of partial normalization of alk-phos, less than 1.5 times the upper limit of normal, and no worsening of a disease stage as assessed by a biopsy based on Ludwig staging. So these patients ideally were supposed to get a biopsy at baseline and another one at 96 weeks. This is a true intention to treat analysis. So if you did not have a second biopsy, you would be actually considered a non-responder. And as was shown just a few minutes ago, 15.1% of patients met this composite endpoint versus 4% for placebo. And that basically was statistically significantly superior to placebo. Pretty good safety profile for this once a day, 1,500 milligram per day dose. Rate of adverse events comparable to placebo, and overall, as far as we are told, well tolerated. Elmwood is a randomized double-blind placebo-controlled phase 2 trial. The data are now published in J Hepatology as of last month. This paper by Dr. Levy basically outlines not only the inclusion-exclusion criteria, which are pretty standard. Of course, you could not have decompensated cirrhosis. You could not have a very high ALT. You could not have evidence of portal hypertension or severe, at least a platelet count less than 100,000. Randomization in a 1-to-1-to-1 fashion to placebo, elafibranor 80 or elafibranor 120. The data we're going to show are out 12 weeks, and there's an open label extension trial of elafibranor at 120 milligrams once a day out to 96 weeks. The primary endpoint was primarily safety here, but there are secondary endpoints, including change from baseline in biochemistries, non-invasive markers of fibrosis, and there are a number of exploratory endpoints, including assessment of itching. And if one looks at the 12-week data, the relative change from baseline in alkaline phosphatase panned out at both the 80 milligrams and the 120 milligram doses. As you can see, the decrement below the baseline is about minus 25 and minus 44.7 for both doses. An alkaline response, according to threshold reduction, was significant across the board. About 69% at the higher dose had a reduction more than 40%, about 56% less than 1.5 times the upper limit of normal, and about 17% actually normalized alk-phos on this regimen. The last agent that I'd like to talk to you about is a CCL24 target known as CM101. It is known that CCL24, through primarily recruiting bad actors into the liver, macrophages, and others, can actually impact histology, drive inflammation, and potentially fibrosis. And this incredibly busy slide basically highlights much of this, including picuo-serous red staining, which you see on the right, that shows that in an animal model, if you abrogate this, you can reduce fibrosis. You can also reduce the number of macrophages that are recruited to the liver, and you can also potentially reduce bile duct proliferation, which is an indication that you're getting less injury. And in fact, there is a study called the SPRING study. This is now published by Professor Bolus and colleagues in the American Journal of Gastroenterology in 2025. And I'll show you some highlights here in the interest of time. There is a decline in liver biochemistries, a modest one, but nonetheless a decline across the board, AST, ALT. This typically seems to happen at the higher dose, not so much at the lower dose of this. This is given either at 10 or 20 milligrams per kilo per body size. It's given every 3 weeks intravenously, which means that if you take it for 15 weeks, you're going to get injections every 3 weeks. If you look at liver stiffness, there's also a modest decline in liver stiffness during that short period of time. And again, this is primarily happening or happening more in a dose-dependent fashion at the higher dose. And this is an open-label extension set of data at 48 weeks, and what it shows is that, again, at the higher dose of this, there is stabilization and non-invasive fibrosis parameters, including ELF. And this seems to be much more pronounced in patients who have at least advanced fibrosis. So if you took all comers, there wouldn't be as much of a decrement or stability of fibrosis, but if you took specifically patients who had more fibrosis, and you compared them on the last panel on the right to historical controls, these are taken from the Corpus Show paper in 2014, where they looked at the progression of fibrosis in PSC, you can see that at the 10 and 20 milligram per kilo doses, you are faring better in terms of evolution of fibrosis compared to the historical data. I'm going to end here, and I'm going to thank all the folks who were kind enough to share slides with me, Kris Kowdley and Gideon Hirschfield, Jason Barnum, Alison Barnes, Megan Smetana, Paul Peloso, and Agnes Costello. Thank you very much.
I'm going to be talking about symptom management, particularly pruritus and fatigue, while the patient is sitting with you in the clinic. These are my disclosures. Cholestatic liver disease is something that's a little bit different from your other chronic liver diseases, where symptom management is part and parcel, particularly with primary biliary cholangitis. It's challenging because the pathophysiology is not very clear, and it probably is multimodal. I'm going to talk briefly about assessment tools, practical management algorithms, some treatment options, and then some future directions. Symptom burden in cholestatic liver disease, while many of us are familiar with hepatic manifestations, assessing the biochemical response and severity of liver disease, portal hypertension complications, PBC, for that we also are, pretty familiar with other extrahepatic manifestations, particularly Sika syndrome, looking for hypothyroidism, other autoimmune diseases, and fat-soluble vitamin deficiency. We are increasingly being challenged to address fatigue and pruritus and objectively quantify the severity of these symptoms, particularly with second-line treatment options showing improvement in these symptoms. So we are more attuned now to address these. And then there are a lot of symptoms that PBC patients describe, and they are vague, they are challenging, and difficult to quantify and document in the clinic chart, because sometimes we don't have a particular designated word to describe those symptoms. With regard to the proposed mechanism of itch, it's very challenging, but I'll walk you through this. Cholestatic liver disease, obviously bile salts, bilirubin. There's peripheral sensation in the skin, and that's carried through peripheral nerve fibers to the spinal cord, and then it is carried to the central nervous system. But completely separate from that, there is endogenous accumulation of histamines, opioids, and then other neuropeptides that can directly affect the brain or through the peripheral nervous system. And as such, you have autotaxin, you have histamines, IL-31. So if the pathophysiology of itch in a PBC patient is primarily through total bile acids or bilirubin, you may have efficacy with drugs that reduce these. But if the mechanism is increased endogenous histamines, you might have better response with antihistamines. And if it is IL-31, which is completely separate from the histamine pathway, you may have to look for a drug that decreases. And there is a drug that is currently approved in some of our refractory itch patients. We do send the patient to a dermatologist for use of that drug. It's a monoclonal antibody that decreases IL-31. And then there have been some trials decreasing, using the mu opioid activity blocking at the central nervous system. And if that is the predominant mechanism for your patient, that might work. So there are many things that are happening. And as you see in the figures, these can fluctuate over time. And these also, can explain the placebo response that can happen in a clinical trial. How do we measure itch? In the clinical trials, the best tool is the worst itch numeric risk score. This is what the FDA is looking at if they want to approve a drug and to show that there is improvement, because it's reliable, it's valid, it has been tested and retested, and it captures the patient experience of itch. How does it work? On the 0 to 10, you have 11-point scale. And you ask how would you rate your worst itch in the past 24 hours, and these are the numbers. And then you have the 5D itch scale, which is going beyond the itch severity and how this itch is affecting the overall dimension of the patient and their performance. So if we were to use WI-NRS is the best score, but again, this is when the patient is presenting to you in the clinic and you're asking in the last 24 hours. It does not capture last month, last 3 months, or last 6 months. So it is a one-time capture. With regard to the treatment, luckily we have the second-line treatment options that address the liver-specific biochemical response, but also improvement in the itch, and this has been shown by Dr. Kowdley. Here you see the numeric risk score over time, and you have the treatment arm and the placebo arm, and there's a difference in the seladelpar treatment trial. There is a difference between the placebo and the treatment arm. And what is clinically meaningful? Generally, 3-point decrease in the numeric risk score is considered clinically meaningful change. And you see this hitting the 3 points with the treatment arm and the placebo at 1.5. And you also notice that you see the biochemical response happens within 4 weeks to 6 weeks, but you see by the time you see an improvement in the numeric risk score that is clinically meaningful, it can take up to 6 months. So you might see an improvement, but for the full clinically meaningful response, there is a lag from the biochemical response to the symptom response. So you might want to tell your patients that yes, you will continue to see the benefit. Wait until the 6-month time point for us to fully realize the benefit of second-line treatment option. And there's another study that shows that where exactly is the improvement in itch over time. This is the elafibranor data. They could not show the statistical significance with the WI-NRS score, but you see with the treatment, the score improves, and over time, the differentiation was still there, but it did not meet the statistical significance. And if the same itch as measured by the 5D itch scale, there was a statistical significance. So sometimes you don't understand whether it is the instrument that did not perform well or is it the drug that did not perform well. So I do think based on the mechanism of action, both drugs do work, and it is up to the patient with regard to what is the actual pathophysiology of itch that is happening in that patient. I did want to talk about IBATs. Thank you, Dr. Gholam. I asked him to spare this topic for me because I wanted to have this hook, because these drugs are now going to be an option for us sooner than later, with IBAT being evaluated for cholestatic itch in adults with PSC and PBC. So the concept is, you intervene in the enterohepatic circulation, you block the bile acids from being reabsorbed, so you decrease the bile acid pool. This is the phase 3 trial for cholestatic itch using linerixibat. You see the WI-NRS score decreasing 3 points, which I think is clinically meaningful, and it is statistically significantly higher than the placebo, and this continues to be persistent over time, maintaining the statistical significance. The data has been submitted to the FDA. The PDUFA date is March 24, so less than a month. We may have this treatment option available to us for use in cholestatic itch. Whether it will be only for PBC or PSC and PBC, I'm not clear, but we can certainly, evaluate for cholestatic itch. So what are the nuances in how we are going to use in the treatment response? So this is the WI-NRS score at baseline at week 24. These are the change in the different PBC 40 domains, and we see that there is some difference that is maintained over time. These are the side effect profile, and you see that diarrhea is what you would expect with IBAT, but there is some noise with regard to the liver enzyme elevation that required the drug to be stopped. So we have to be a little bit familiar on how safe we can use it and what kind of monitoring we need to be doing with regard to the IBAT use for cholestatic H. And then Dr. Kowdley already mentioned that the baseline total bile acids are not predictive of treatment response. So, how do we go about using this? So this is what I'm thinking. If a treatment naive PBC patient shows up, obviously first line is UDCA, and you evaluate the biochemical response, whether you do it at 12 months or 6 months, and the cutoff you use for alkaline phosphatase 1.5 or 1.9 if it is a 6-month evaluation. And if there is no biochemical response and there is H, it's a no-brainer, you go to the second line treatment. And then if there is biochemical response, but the patient continues to complain of H, do you go to second line even though alkaline phosphatase is normal, or do you go into stepwise pharmacotherapy that we all have been doing for several years, or you go to an IBAT inhibitor to add on to your UDCA and then second line, and then an add-on IBAT. There's not much data on the combination of second-line treatment, PPAR and IBAT together. They are different mechanism of action, so there may not be much overlap, but I don't know the safety aspects of it. The other thing is I already talked about, you are measuring at the time of your clinical encounter, but you are not necessarily measuring what's happening to the patient over time. So there is this group that has done an app-based approach where the patient is continuously entering the symptoms over time. And interestingly, the number one is fatigue, joint pain, concentration difficulties, abdominal discomfort, dry eyes, dry mouth, cramps, swollen feet, and then, it's severe liver disease, you can have some complaints of jaundice. But itching was somewhere around 60%, but there are several other symptoms that the patients actually are debilitated from that are beyond itch and fatigue. Our group at IU has an app that is being used, but we are optimizing it for cholestatic H, so it is possible to use app-based. If I made pathophysiology of itch very confusing, forget about understanding fatigue. It is very complicated, but I'll make it very simple. There's central fatigue, which is lack of intention, memory impairment, sleep quality, and daytime somnolence. And then there is the peripheral fatigue, where there's actually fatigue in the muscles. Maybe there is disruption in the mitochondrial pathways causing inability to exercise and things like that. Measurement of fatigue is even more challenging. There are several tools. Some are paper. Some patients can mark by themselves. Somebody has to deploy the instrument, and some are computer based, but most are generic tools. They are not necessarily customized to cholestatic liver disease. So treatment of fatigue, at the most we can do what we think within our reach, which are the contributors to fatigue, hypothyroidism, since it is common in PBC. The one thing that I'm very big is the sleep apnea, or ordering a sleep study and seeing if it is contributing to the fatigue, and then medication-induced side effect, things like that, sleep hygiene and pain. There's no drugs that are currently approved for treatment of fatigue in PBC or PSC or any liver disease, but there are some small studies where we use off-label modafinil. But there is increasing interest in exercise program, CBT, particularly those where we talked about peripheral fatigue, so stimulating the muscles, converting from anaerobic to aerobic maybe can help with the fatigue. There is some data with elafibranor on fatigue. It did meet statistical, I don't think there's a p-value, but this is not a key secondary endpoint, but there is difference in improvement in fatigue with elafibranor, but there's no data on seladelpar. With regard to safety slides, fair balance talk, it pops up randomly, but this is the safety on seladelpar. We might want to talk about, fractures, CK elevation with regard to the second line, but we'll do that at the round table. This is the elafibranor. With regard to the treatment of fatigue, I do recommend exercise regimen, particularly aerobic, and then anything that can improve daytime somnolence over cognitive function and quality of life. We have worked with Punita Tendon in Canada, referred some patients to yoga and Pilates and any kind of just get up and start walking. It's easy for us to say, but they may be very challenged. There is increasing emphasis on how we manage patients with PBC, particularly symptom management. There is a value in seeing the patient for an in-person visit compared to tele visit. This is something that we are increasingly conscious about, asking for an in-person visit for patients with PBC. Talking about Zika syndrome, getting a liver stiffness, and then if cirrhosis, ultrasound hepatoma screening. We always encourage them to join a peer support group, PBCers, so they can share their experiences with other patients suffering from PBC. We don't have a standardized way to capture these symptoms, but we are planning to deploy an app-based capture of symptoms for patients with PBC. So where I see this going is individualized therapy. Yes, we all know how to do biochemical response. We are pushing it to complete normalization of alkaline phosphatase, bilirubin less than 0.6, looking at 6 months versus 12 months, LSM at baseline and follow-up and combination of LSM with GLOBE score, and then asking about symptoms, and then, when we intervene, documenting an improvement with second-line treatment. But we are still struggling to figure out how best to quantify these symptoms. And we don't have great biomarkers for itch and fatigue. So with that, we will get to the roundtable. Thank you.
And I should have introduced Raj properly. So he's a professor of medicine, director of hepatology at IU, and publishes in many areas, including DILI, cholestatic disease, and MASH. So thank you, Raj. Sorry for not giving you the props there. So we have some time for Q&A. I'll start off by asking Aparna about PSCs. A lot of questions, very few answers. But one of the things in PSC that I think is really interesting is that itch is a real issue in patients with PSC, and I think we don't think about it much because we're so concerned about cancer surveillance, colon cancer, gallbladder cancer, bile duct cancer. The patients are overwhelmed. But in fact, itch is, not uncommon in PSC. We just published a patient survey that was sponsored by Mirum, but really from patient groups all over the world, of over 400 patients. Now, this is self-reported, and surprising, over 90% of patients who had this PSC patient self-reported that they had itch at some point or another, with a significant percentage reporting bothersome itch. And another paper from a multi-center study in the UK just came out in Journal of Hepatology suggesting that 25% of patients with PSC actually have itch that we would consider moderate to severe NRS 4 or more. So I want to ask everybody really on this panel about whether they were impressed by these data, whether you think itch is an issue in PSC, and whether there would be a role for IBATs in PSC itch as well. And there is a trial that's ongoing with volixibat for PSC-related itch and also for PBC. So I'll just start with you, Raj, and have each of you talk about whether you think itch is something that is a real issue in PSC.
It is real for those who have it. And when those patients complain, they are usually difficult to manage. But we all have our own formulas on how we go about, algorithm-wise. I do get tempted with off-label, fenofibrate, but I do worry about drug-induced liver injury in those with elevated bilirubin at baseline. So, I do a variety of things, but I am looking forward to IBATs if the FDA is going to approve for cholestatic itch versus PBC itch only. So that we'll know in a month.
To answer your question, your data is very impressive. Good job with your study. I think itch is very prevalent. It's underreported. It's underasked. And I think that's true in all chronic liver diseases, especially in cholestatic liver diseases. We saw it in PBC with what we thought the prevalence of itch was, and then target PBC data came out indicating it was very prevalent. And I think similar to what you guys are finding when you did your survey is when we do validated instrument tools, those are taxing. Those can take time to fill out. I think that sometimes what the true prevalence isn't necessarily easily reported in those instruments. But when we ask our patients, I think 7, 8, 9 times out of 10, they will say that they have experienced itch at some point. So I believe it. UDCA and PSC doesn't usually treat the itch, so if we are going to use it, it's not going to do much for it. We do need to address it and treat it differently. So we'll see with elafibranor and as it gets studied in PSC how that might impact itch, but I think also looking at how the IBATs do in PSC. I think the interesting thing with the IBATs in PSC is a lot of our patients with PSC have IBD too. So the risk, the adverse effects of diarrhea, I think we have to be kind of mindful of also in that population. But I am looking forward to it.
Yeah, I think it's not so much just underreported, but also undervalued by patients in terms of what the decrement in quality of life really is. I guess a classic example that jumps at me is a patient who has been itching all their life. I diagnosed them with what I think is adult inherited cholestatic liver disease. I prescribed them an IBAT inhibitor, and when the patient was called 2 days later, the patient said, I did not realize that I had not been sleeping at night for 20 years. This is the first time in 20 years that I actually put my head on the pillow and woke up at 7 in the morning. And so I think it's the resiliency of the human spirit that people get used to horrible quality of life and don't really want to make much out of it. And we probably should do a better job of eliciting this history in a patient as opposed to just generically asking about itching.
Yeah, I think that's a really good point, especially now that we have potentially IBATs available in the clinic, and since genetic testing for cholestatic disorders is now available to us really free, made available by some of the companies that have medications, we're seeing more and more patients that have PBC and MDR3. Or some other sort of variant that could be contributing, and potentially that would be an indication for considering therapy. And I think the fact that we are now able to incorporate patient-related outcomes and symptoms is, really, really great. So, Aparna, you're still in the hot seat. So I'm going to ask you a couple of questions about PSC because I'm still not sure that we're doing the right thing. I've, for purely reasons of maybe treating myself, have taken the tact of doing alternating MRCPs and ultrasounds every 6 months in non-cirrhotic patients with PSC. Obviously, we know about the gallbladder polyp issue. What's your approach to surveillance, and how do you kind of read the recent data about prevalence and outcomes with surveillance, cancer surveillance in PSC?
Yeah, so for newly diagnosed patients, and I agree with you, I don't know if I'm doing the right thing either, but I'm following kind of what the guidelines are saying. So for newly diagnosed patients, I do initially start with annual screening. So I'll do it once a year, but there is some concern, once a year MRI, MRCP with CA19-9 for cholangiocarcinoma screening. There is some data that maybe gadolinium has long-term impacts. We see it depositing in the brain. We see that maybe there is some risk to doing, if you start at the age of 25 and you're doing 40, 50 MRCPs or MRIs, then that could be a problem down the line. So if I have seen that there's stable disease, meaning that there's no new biliary strictures, liver tests are normal, ELF score is relatively stable, or transient elastography scores are stable, I do sometimes talk to my patients, share decision-making, and space it apart to 18-month, 24-month intervals if I think they have relatively stable disease. I haven't missed a cholangiocarcinoma yet by doing that, but it does make me nervous. I still do the CA19-9s, and I still will get the ultrasounds in between. So just in case there is something small that pops up, then I would follow it up with an MRI. And then gallbladder polyps are a challenge. It still is recommended to do annual ultrasounds for polyps. The MRIs are not sensitive enough to detect, smaller polyps that are like that. So our radiologists do still recommend it, and we are still getting the annual ultrasounds done. And then colon cancer screening is, for PSC-IBD, it's pretty straightforward once a year. But if you do not have IBD and you only have PSC, there's no great data to support what we should be doing. What I offer is usually every 3 to 5 years, but the actual, from a population level, it looks like the incidence of colon cancer and PSC when you do not have IBD is actually probably similar to the general population. So you may be able to follow what the general population guidelines are.
Pierre, is that also your approach? Do you have a different approach?
Yeah, perhaps a less targeted approach that I use is every patient who has evidence of stricturing disease, on imaging, I do alternating ultrasounds and MRCPs every 6 months, and I check an AFP and a CA19-9 every 6 months. Maybe that's overdoing it, but that's what I've been doing. So, yeah, and I don't know if I'm doing the right thing or not, but I don't know what else to do. I'm open to suggestions. So.
Well, a little bit different at IU is we have MRCP Plus, and we've been doing that for last 2-3 years. For a new diagnosis, I'm a little bit more aggressive with the MRI, MRCP, because most cholangiocarcinoma diagnosis occurs early on. But after a certain time, if the alk-phos is normal, I get away with the ultrasound.
Great. Well, I thought we had more time for questions, but we're already past our time. So we'll be around. I'm sure that many of you have patients you want to discuss with us or anything else, or tell us how you might be handling things differently. So thank you so much for this session. I want to introduce, thank you.
Hello, everyone. We don't have time for wrap. Just wanted to thank a few people, starting with Dr. Bacon. I also interviewed with him when I was a fellow, and he gave me some very good advice. So a great tribute that we gave to him this morning, and thanks to his family for lending him to us. And I'll wrap up with one more thing. We won't have this meeting if Danielle and her group would not organize a meeting like this in the first place a few years ago in the beginning of COVID. So just a round of applause for them. And then they really do work very hard to find the venue, and the steering committee takes the credit. And I think they deserve a lot. And the dinner is right outside. And this is a wrap up, but the first day is not over yet. You just come right back in for the last talk of the day. And then we'll end the day, and we start early tomorrow morning. Thank you so much for attending this meeting.